thanks for bringing that outlook and all the insight. Nina really touched on two important points that push against, the throw up your hands kind of a posture. One is that we've got clinical research going back 10 and 12 years that says small gestures, small observations. The Health Buddy study is going back that far. Now everyone's carrying a text machine. It doesn't have to be patient specific. It doesn't have to be diagnosis specific. It's just a pat on the back once in a while that weaves in between this. Some of the stuff we've taken from movement cessation programs is very powerful. And these are tools that we've only had universally, not universally in a global sense, but we've only had universally within this system for the past 4 or 5 years. The other thing, that's something we can do more of. That's something that needs to be explored. There's also something that Nina touched on that we can do less of. And I uncovered this in some diabetes research about 10 years ago. One of the dozens and dozens of silent costs, of silent pains of chronic disease is being a debtor. That if you've got 3 specialists and DME and 3 office visits a quarter and supplies and 2 different insurance carriers to pay for, you've always got a past due notice on your dining room table for $10,000. And you get used to it. You sort of quietly, it's one of those pains you just absorb. But if you started out as one of those people who that bothers, who's conscientious about that, it's just one of those quiet things that people can't even access. They can't even respond to it. We got to do less of that because that's contributing to the incidence of depression, sort of the low-level costs associated with mental health.
I want to say that in general, from my own experiences as a clinician as well as in research, that life and healthcare is really a team sport. And so many of you talked about that in one way or another, although you pretty much said most is my healthcare team, what about my team? And I think that's a piece, if we can use data, whether it's natural language that we can extract from a qualitative standpoint, or any other kind of interactions, is how can we build better teams? Folks can't make good decisions if they really don't understand what my sodium level really means. Some of it is based on where they are in life. Are they 12? Are they 20? Or are they 50? But where's the team piece? And that's what I want to know. Have you seen anything related to that? And then how you use that data that y'all are collecting to make education better from a healthcare side as well as from a patient side?
So I can speak to the team. Using technology to enhance teamwork, right, to achieve people's goals. So we recently participated in the challenge. So it was a VA challenge, Veterans Administration challenge for care coordination. So there was like a big competition, nationwide competition on creating an application that will put together structured, unstructured data in some way, right, to promote care coordination and team-based care. And this application, the main goal of this application is to be driven by the patient goals, not by what the providers say, but those harmonized goals, right, between the patients and the providers. So we were able to pull together the technology that will look into the unstructured data, take out the care coordination, care planning pieces, kind of recommendations from different types of providers, put them together, help review those different recommendations from different types of providers, right? And then reconcile them to one type of recommendation. So let's say, measure your blood pressure so and so times a day with this frequency. Or do your physical therapy exercises, so and so. That's kind of the way of the future. I think the technology should kind of put this whole thing together, this data that's coming from different sources. But yeah,
I would just add that I would add too that it's really hard to be a team when the fundamental economics of healthcare is highly individuated and highly focused on the physician. Increasingly, nurses in certain types of care settings can prescribe and treat patients with oversight of a physician. That could be a physician walking the halls or sitting in the other corner of the building for all we know, but the system as it currently stands in terms of the financing and the funding is not conducive to a team-based approach. Now, there are breakthrough models. There are innovations that are happening there. I would cite, for example, Iora Health, which is basically a primary care practice that doesn't accept insurance. And they work with employers to cover the primary care needs of employees and dependents for a fixed fee per month with a guaranteed appointment time of 24 hours or less. You have your own dedicated care team, and your employer covers that and also gives you a catastrophic rider for should you get run over by a bus, God forbid, or something that happens that requires hospitalization. So I think there are things that are happening that are going to make the technological challenges less onerous and move people in a direction to say, we can take better care of patients by getting out from under the fee-for-service tyranny of piecework and accept a fee per month for a family from an employer and give them all the care they need and keep them out of the hospital. And those are the kinds of things that are showing team-based types of models where you've kind of taken the classic incentive structure, turned it on its head, and suddenly you have care delivery models that are much more focused that way. But the fee-for-service model is basically a physician reimbursement or an institutional reimbursement model that doesn't support teams. It's very hard to get them together, keep them going, and establish that kind of environment, that kind of ethos, if you don't have a payment system that's right behind it and helping reinforce it. So I think that's part of what's going to improve the team-based approach.